Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Ami Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Gurevich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
All right. Welcome back, everyone. We've got yet another exciting episode today. Dr. Gurevich is going to be talking about neurotherapy. I don't know a ton about it. I just know that she likes to inject people.
I really do. I find it very useful. So
I will just mention, I was at a regular conference for pain management, and they actually mentioned neurotherapy and perineural injections. They didn't go into detail, but they mentioned it as potential options for people as far as, you know, the whole scope of what we're using for pain management.
So can I say like my context on it?
Okay, great. Yes.
So I think of it as helpful for scarring.
Yes, very much so.
Inflammation.
Yes.
Pain.
Yes.
That's all I know.
Okay.
And it involves needles and you're putting stuff in.
I do.
And I've had it done.
I've had it
Have
done
I
too.
injected
And it
you?
actually helped. No, but someone you trained injected.
Have I injected you?
Probably.
Or David Chang? Maybe my business partner injected
Probably
you.
both.
You've
Okay.
offered many times.
Okay, yes. It is one of my go-to tools. So I do have to say, I do have a disclaimer because I do have a financial interest. I do run a educational neural therapy program with my coworker, Ann Hill. So disclosure, just for that, just to know about that.
And it can be really useful for GI conditions.
And for psych.
Ooh.
Yeah. Okay, so
no one has that combo.
Nobody has that combo. So neurotherapy, let me just tell you guys how I got into it.
Okay.
And then what happened from
The
there.
origin story.
The origin story. And the origin story comes full circle because it actually starts at the VA. So many of you know my father is a psychiatrist and my father is a holistic psychiatrist. He is one of very few psychiatrists who specialize in getting people off of medication and not putting them on. And one of the things he did is he went to acupuncture school for psychiatry and like brought acupuncture in.
I didn't know that.
Mm-hmm. That's actually how he started his alternative medicine journey.
Wow.
Is he went to like
He's an acupuncturist.
He went to an MD certificate to learn acupuncture.
Wow. Huh, cool.
But what he kept on reading about the VA running all of these clinical trials using neural therapy for complex PTSD, doing a stellate ganglion,
So
right?
it's been around for a long time.
Oh, is stellate ganglion block part of neurotherapy?
Sure is.
Okay. And
should you explain what neurotherapy is?
Sure. Neurotherapy is an injection-based technique where we use Procaine, which is actually the first ever anesthetic discovered to basically reset the way the nerves innervate the different organs. So it's really important. Procaine. So let me back up. To be a good anesthetic, the anesthetic is supposed to be lipophilic hydrophobic, right? Okay. It's supposed to like fat so it can stay on the nerve, which has a myelin sheath or a fat sheath around it. And it's supposed to hang out there for as long as possible. Right. And that's the length of time that an anesthetic works. 4 hours, 12 hours, 18 hours. You want your anesthetic to be lipophilic hydrophobic. We use Procaine. And Procaine is hydrophilic lipophobic. So completely backwards. Procaine will go to nerves, but it doesn't hang out there for very long.
Okay.
However, Procaine happens to be made up of the perfect sodium and potassium mixture that what it does is when you introduce it into a nerve, it causes that nerve to repolarize and reset. Like the equivalent that we use is when you're having a tech issue with your computer and you shut it down and then power it back up. That's what Procaine does to your nerves.
Okay.
That's really important because a lot of people will get caught in either a hypoexcitatory nerve composition or a hyper. Like there are people whose nerves get turned on and just stay on.
So is this like, I'm thinking of visceral hypersensitivity.
I
And
definitely use
maybe
it for that.
Cool.
central
That's great.
sensitization.
I definitely use it for that. I mean, and there's a lot of different ways to use Procaine
Right.
as a tool. One way is to do it the way I'm doing it, which is injecting. But another way is to use it as an IV. You know, in this world that we live in, with all of this information coming into our brains through our devices, through the news, through fear and all that, a lot of us are just stuck in this hyper excitatory, like our nervous system is fried
totally.
from the inside out.
We should have had you bring some today.
I know. I know a person. So bad.
But however, so we have this very effective, not very expensive tool.
Yeah,
where
Procaine's pretty cheap, right?
Procaine, well, it's not as cheap as lidocaine. It's not as cheap as it used to be. I learned, because one of the things I did was I taught a class at the North American Academy of Neural Therapy.
Yeah.
I taught their intro level 1, which is what me and Dr. Hill teach all the time. And they brought Procaine from Canada, a third of the price.
Oh, wow.
Procaine doesn't have to be expensive, but it does have to be compounded. And our compounding pharmacies, it just costs them more.
Yeah.
Huh.
So Procaine is basically, you're using this substance. It's an injection-based technique, and you're using the substance to reset the nerves. That's really important, but that's like what you're doing. The why is a little bit different. The theory of Procaine really settles into this understanding of an interference field. An interference field. Okay, so, recap of how nerves work. From the brain to the spinal cord, right? That's the CNS. Once those nerves leave the spinal cord, now you're in the peripheral nervous system, right? And those nerves go from the outside of the spinal cord to the organs, through the muscles, to the skin, and then circle back around and go to the CNS again, right? It should be a circle. What will break that circle?
So this we learned.
Scarring.
Yeah, scars,
Scars.
surgeries, certain organ dysfunction.
All of those.
Right. Willies.
Let's start with scars. Because scars is the easiest, most tangible one. And, when you say neural therapy, I think scars. Yeah. You're absolutely right to think scars.
Yeah.
Scars, what happens is you're cutting.
Piercings.
Some piercings are interesting. Well, I'll get there.
No.
Scars are cutting the transition of those nerves. And remember, like, if you look at nerves, it's all like they're all starting at the big guys and then they're getting smaller, but those smaller ones feed back into the big guys.
Yeah.
So if you've got a big old laceration, that's kind of a problem,
right?
Because now those nerves are blind.
Downstream. Yeah.
And the other thing to remember is, like, it forks. And so you might have a scar, say, on your foot or on your arm, but you might be having chronic neck pain or chronic back pain.
Yeah.
Totally.
Because that blind spot on your nerve, on your arm, on your leg is still going to hook into that big eye at the end.
So this makes me really think about the abdomen, because our innervation there is already kind of bananas, and the referred pain patterns with gut stuff and whatnot.
Yes. So
we cut into abdomens all the time.
So I think Dr. Chung would always just inject everyone's scar, like a lot of scars.
Well, I will tell you that I also, that is the first thing I do with any neural therapy treatment is I take an inventory of scars and then I inject, and it's kind of incredible how it changes things.
So what about, this is kind of a tangent, but these like minimally invasive procedures that we're using more and more that on the outside are minimally invasive, scarring, like laparoscopies, but inside...
So the second thing about the interference field, there's the scar, but there's also the emotion. The emotion is really important, because if you're going into a surgery and it's really scary and you spend the whole, month before like revving and nervous and not sleeping on a point of panic attacks. And then afterwards you're scared that something's going to go wrong or something did go wrong.
No, so many people.
That emotional charge also feeds into that nervous system and that interference field. So not all scars are inherently going to be bad, but if a scar is highly emotional,
emergency surgeries, people are freaking out. Just go under. Yikes.
I have this really interesting patient case that Anna and I discuss when we teach. It is okay. So there was this child. She was 4 years old and she was an immigrant, and she ended up getting a massive burn right? And so she was 4 years old, and her mom had to take her to the hospital. They were immigrants, they didn't speak English, and the mom kept on being very, very afraid that Child Protective Services was going to come in because the child had a burn. So now the mom is very anxious. The child's in acute pain, but the mom was like trying to control the child, and she was like, shh, 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 you know what I mean?
Yeah.
And because of the size of that burn, it was a massive burn, they had to graft her. So they took a graft from her leg and put it on her arm to try to get that burn to heal.
Yep.
It was a very traumatic experience for her, very traumatic, and it happened at the age of 4. She went in, and she was actually a patient of my co-teacher, Ann Hill, and she went in, and Anna injected the scar. And when we injected the scar, we actually did it in class. When we injected the scar, she like dissociated from her body.
Yeah.
And and the nice thing about teaching with Anna, she also does cranial sacral, and so she was able to like help her ground.
Yeah.
But afterwards, the patient reported that she had never felt like her arm was part of her body.
Yeah.
She couldn't track what it was doing. It was very unattached from her.
Right.
And then something about reconnecting the nerves right in that area just gave her awareness of this entire part of her body that she kind of was just like dragging around.
Yeah.
Like that's the power of doing a neural therapy injection.
Yeah.
And so with our patients who have a whole lot of emotional aspects to their physical pain,
Right.
it's huge.
Yeah.
And you may be able to have some people achieve the same results with acupuncture or body work or et cetera,
Totally.
but it's one way to do that.
It's like a different level.
Yeah.
I personally, being trained in both acupuncture and neural therapy, I personally view neural therapy as acupuncture on steroids.
Yeah.
Like,
that's what it feels
I mean, it is. It's like I use the same points that I'm going to use in acupuncture.
Mhm.
I use the same Chinese medicine philosophy. I just use this substance as my injection.
Cool. Yeah.
So, okay. So that's like interference fields and emotional. We are a digestive podcast. We are called the Turd Nerds.
This
for
must
good real.
connect somewhere.
This is okay. So I started this training because my dad was interested in learning the stellate ganglion because the VA was using it for complex PTSD.
But that's a little bit of a dangerous injection, or not so much? Only
So
for people who don't know what they're doing.
It's
like us.
so that's a very important question because the stellate ganglion, the way they're doing it is they're doing intra-articular, so it's ultrasound guided.
Okay.
When we are trying to reset the stellate ganglion, we're actually doing it outside. Like, so we're basically going in between C5, C6. And then we're using the patient's position to allow the Procaine using gravity to drip to the stellate ganglion. So it's much less dangerous for me to do an intra-articular than what they're doing in the VA under ultrasound guidance. But that was part of his problem. His problem was that no anesthesiologists were like, no, this is an anesthesiology thing. Like, it's not a psychiatry thing. And that's why he couldn't learn it. And he's in private practice.
Okay.
And so what happened was that he started bringing teachers, because neural therapy is part of the medical system in Colombia. It's part of the medical system in Switzerland. It's part of the medical system in Germany. Like, there's congresses of European medical doctors who are using these techniques.
Yeah.
We were just very blind to it in the US until fairly recently. So he started bringing out teachers from, from Switzerland and Germany and all those places. And he was like, come.
Yeah.
And so actually a bunch of us naturopaths, including me, I was like, yeah, I'm going to go stay at home for free with my parents, go to a conference for free with my parents. You know what I mean? Like, it was great. And so a bunch of us went and we started studying neural therapy with these teachers that he was bringing out.
Yeah.
And I don't like psych. Like, I worked with my dad for a year in New York. Those are not my patients. I'll take psychiatry light any day of the week. Touch of anxiety, bit of depression, nothing more serious than that. You know what I mean? But so I was using it on my GI patients.
Yeah.
And the effects are so interesting. One of the most effective places to use neural therapy is for people with chronic reflux, actually.
Cool.
So
where are you injecting it?
Great question. Great question. So there is a very simple protocol that really tracks nerves that innervate the anterior and posterior aspect of the stomach and the esophagus, which is where I'm injecting.
And like any cause of reflux?
I don't ever start with injecting them, right?
Yeah,
like, I'll start with all of the things we talk about 100 times on the podcast.
But I'm thinking if it's like
recalcitrant
hernia or, like, what was someone I had recently, esophageal strictures, like different like mechanical things getting in the way, or is it just like we've, kind of treated the SIBO, done the things, nothing's better?
That's when I'll start.
Okay.
But have I seen it work for mechanical disruptions? Yes.
Because those are hard.
Yeah, much harder.
And there's like a textbook of where to inject for which organ system, correct?
Not only is there a textbook, there's 2 more textbooks coming out this year.
Oh, okay.
That's cool.
David Vignea's just published one. And there's this incredible female, Dr. Laura, I can't remember her last name, from Columbia, just published one.
Okay.
And they're both going to be published in English.
Yeah.
So
the first one's in English, right?
There's one textbook called Dosh.
Okay.
The Dosh, if you ever read that book, the joke that is about that book is there's a woman model and she's naked. So she's topless if she has to be or if she doesn't have to be. She's just always topless because it was the 1970s. There was like a different, it was a different etiquette.
Let them hang.
But there's 2 new textbooks that are coming out. But the Dosh book is very useful because they'll show you where to inject.
Yeah.
There are some, the Dosh book was written in the 1970s, so that we've made a lot of updates. And in fact, Dr. Lauda in Columbia actually did a fair amount of research where she was using cadavers to be able to see exactly where she was injecting and exactly where gravity can pull the Procaine
Weird.
to see how you're resetting the ganglion.
Wow.
Weird.
That's dedication.
If you listen, I have another podcast called The Point of Medicine, all about neural therapy, because I love it. And we interviewed her, and basically when she was at the end of medical school, she was like, I don't want to do medicine. All I want to do is neural therapy.
Yeah, cool.
And so she only does neural therapy for 20 years now.
Wow.
It's kind of amazing.
Yeah.
And so neural therapy. So reflux is a place where I use it a lot.
Yep.
I do have very good efficacy with very, very complicated, like chronic pancreatitis.
Oh, yeah.
It's difficult to treat. We don't have a lot of solutions.
Yeah. Do you think because of inflammation or scarring or signaling?
I think, but my theory, and I don't know, but my theory is we're waking up the nerves that innervate the pancreas.
Yeah.
That's the best theory I can come up with. And, there's a lot of different ways to do neural therapy. The easiest, most simple way is to do what we call segmental. Mm-hmm. It's very, very safe. Segmental is literally subcutaneous.
Yeah, I think that's what I had.
Yeah, very small.
Felt like a bunch of bee stings.
A bunch of pokes. Yeah, it's not very pleasant. Yeah. But it's very, very safe. And so
it goes away quickly.
And it goes away very quickly.
Yeah. And I'm a baby. I'm a real baby, and I survived it. So I just want to say it wasn't that bad.
Yeah. So, and we're using
the
really
worst
little
is the
needles.
tonsils.
Ooh.
Tonsils are a big one. Okay, so let's stick with chronic pancreatitis.
Okay.
Oh man, I'm really curious about that one though.
With chronic pancreatitis, and then I'm starting to use it right now with steatohepatitis or MASH, like basically inflammation of the liver, inflammation of the pancreas.
Yep.
Those are generally very superficial.
Yep.
So subcutaneous, you're not going deep. That is one way you can practice your whole career as a neural therapist just doing these very superficial injections.
Yeah.
I don't do a lot of them because they're pokey.
Yeah.
What I am more likely to do is I'm more likely to do the deeper injections. Mm-hmm. So I'm more likely to inject ganglions. When I inject ganglions, I'm using not super long needles. I'm not using spinal needles or anything like that. 1.5-inch long needles, 27 gauge.
Sounds pretty long.
Yeah.
Oh,
well, I'm not an injector, so to me it sounds long.
There are worse acupuncture needles, we'll say that.
So the other injection that I love more than anything else is doing a pelvic.
Oh.
And my experience with me is, so I teach these classes, and then we'll have like labs where the students, if they're not feeling confident, will come and they can practice on each other, and we'll just supervise and whatever. And after
like pelvic floor or like ileocecal valve situation,
pelvic
I'm curious
floor.
about that too. Ooh.
Oh my God. It was okay. So I was in this, when I was having such acute stress, I was kind of perimenopausal, I'm of that decade, and I was having night sweats every night. And at the end of this lab that I was hosting, that I was running, I was like to one of the students who they basically injected with me in class and maybe a couple times on their own, but they were taking the lab. I was like, hey, can somebody just give me a modified pelvic very fast? So this also goes by Frankenhausen. That's the name.
Yeah.
And so I had her give me a pelvic injection, and you're feeling it. You're going in like right above the pubic bone, where the pubic bone meets the rectus abdominis. That's your entry point. And then you're directing it like basically towards the anus.
Wow.
Right. So that's your entry point, 1.5-inch needle. And you do it bilaterally. And she injected me, and I did not have night sweats for like
What do you think that was about?
I think she like jump started my uterus. I think the Procaine, the substrate that we use, Procaine, resets the nerves that innervate the uterus. That story has happened time and again. I have a woman who was really very close to menopause.
Yeah.
She was starting to have periods every 3 months, every 4 months. By the time I injected her, it was every 6 months.
Yeah.
She bled regularly. She started having regular periods for another 2 years after an injection.
Yeah. So ovaries as well.
It's just it's that whole nerve bundle.
I wonder about fertility implications.
I use it before somebody is trying to start their fertility journey if they've had a hard time.
Got it.
So absolutely, that is one of the things that I use.
What about if they have a history of pelvic inflammation, like endo or Crohn's? Or
yes,
yeah, that seems like
the
no-brainer.
other. I mean, here's the other piece of it. Neurotherapy is very effective for the psycho-emotional piece, right? And so the other thing that women are carrying around all the time is the trauma in the pelvis, and actually not just women and men. The trauma in their pelvis.
We pack it down. Yeah. And then, fertility journeys, even
oh
more
my God,
so
much
you don't
trauma.
have any place to put that.
Yep.
So.
Yep.
Yeah,
so that's the other place where I'll use it is the psycho-emotional. And then the other thing that we do a lot is we do a lot of like emotional. So there's a treatment called the crown of thorns.
Oh yeah, had that one.
It's really useful. It's really good for brain fog. It's really good for chronic headaches. Crown of thorns is basically using Procaine, and like you imagine it like any place Jesus had the crown of thorns when he was.
I've seen that.
Yeah. So that's the injection. But what happens is that people will just get really, really quiet and they'll go internal and they'll kind of like, we call it a lightning reaction. They'll just like kind of go into that yin state where they almost fall asleep and their whole nervous system resets.
How long are they in that?
It's not like they're sedated. They can wake up, they can stand up whenever they want.
Do it once a day in the morning.
So how long does it last?
Great question. So Procaine is out of your system in 20 minutes. That's it's not a good anesthetic, right? Like it's hydrophilic lipophobic. It goes to nerves, but it pops right off. It is out of your system in 20 minutes. But how long do the effects last? Sometimes you need one injection. You don't need to inject them anymore because it's so good. Like it's very effective at resetting the nervous system. And then can I quickly talk about the Procaine IVs?
You can, but do you do the stellate ganglion block for people with severe anxiety and PTSD?
So I will definitely do the stellate ganglion. I will also do the first cervical ganglion, which feeds into the vagus nerve.
Because not a lot of people in the city do those.
Vagus nerve is helpful.
Yeah, I can't.
So
be
it's
the
good.
Only
There's a couple. Yeah.
I did learn how to inject the vagus nerve directly. I will say that right above the vagus nerve, it's called either the first cervical ganglion or the superior cervical ganglion, and so that one innervates part of the head, but it also innervates the vagus nerve, and so I'll use that type of injection for like dysmotility, gastroparesis, dysmotility, chronic pain of the abdomen, stuff like that, and chronic anxiety.
And I wonder about trigeminal neuralgia and stuff like that.
So for trigeminal neuralgia, I'll just inject the trigeminal nerve.
Yeah, that's it.
Will I say that it?
I know David Chang had a case, but I don't know what all modalities he used that it.
I think that I'm more likely to use perineural than Procaine.
We can talk about
that.
So
perineural uses dextrose.
Okay.
Perineural is really better for pain. Like Procaine is actually good for the GI tract.
Got it. Okay.
So we can do IVs, but I'm curious about like ileocecal valve scarring because that's another tricky one. For microbiome issues.
What I'm more likely to do, so when we teach, one of the things that I teach is what we call the Asher treatments. So basically what I'll do if I'm going to inject somebody's abdomen,
like
Asher points in Chinese, which means
wherever,
right there. Like it literally translates.
They're just like not on the
right there
normal diagram.
Yeah, it's like you feel right there.
Yeah,
I'm gonna inject right there.
Like you have pain here, you just plop a needle there, even if it's not a actual acupuncture point.
So one of the treatments that we do is what I call my Asher Chinese medicine treatment, right? So first things first, I'll inject every scar, especially scars that hold a lot of energy and emotion, because that's going to be the interference field. That's going to shut down the nervous system's communication. But then I'll do a physical, I'll palpate their abdomen because I do that all day long. And you can feel, the best way I can describe it is neuromuscular bundles.
Yeah.
Right? You feel like it's a hardness. It feels like a pebble.
How
almost.
Deep are you palpating for that?
A good amount of pressure.
But
yeah.
Like
I'm not digging in.
Layer?
I'm probably somewhere between fat and muscle.
Okay.
Yeah. I'm good in there.
Yeah.
And whatever I feel, if it's a tender point, I will literally just inject right there.
Mm.
Put half a cc, put a cc of Procaine right there. And then the other thing that I'll use a lot is in Chinese medicine, we have this treatment that's called a diamond treatment. CV4, CV12, stomach 25, or stomach
We
or
went to
spleen
like
13.
slightly different acupuncture
Yeah,
schools.
true.
We have slightly different names, but it's fun to hear the different names. Yeah.
So I will use Procaine treatment, but on the diamond.
Yep.
And then so that's where I'll inject.
Yeah.
And what I feel is that like IC valves, if I can find that scarred IC valve when I'm palpating, I'll usher right there.
Can
right
you
into
palpate
the IC
it?
valve.
Right into that area.
Okay.
Can you feel it on palpation? Can you guys feel that? Or you mean if you just suspect that?
I'm not good at feeling it if I suspect it. Can you feel it?
IC valves?
Yeah.
Yeah. All the time, especially if they're bloated and the gas, and then you release it and it's like through the tube.
I don't know why you don't inject.
Maybe I should.
I mean, honestly, the reality is that if you have hands that can feel this stuff, adding a needle into it is like one of the best tools we have.
The reason I'm asking about this is because some people, like, I can move diaphragms, I can move ileocecal valves, I can find where all the organs, and I feel pretty solid with the anatomy. But sometimes people have just such intense scarring or emotional things that are just there. I can move it,
rigid.
Yes.
But the second they come back in, it's like we're just it resets, but they can't
Doesn't
get
hold.
any. Typically when I'm working on people with a lot of that stagnation, it's like if they do the deep breathing, if they do the homework, if they come in regularly, over time their body relearns that it can release and be safe, and whatever is locked up in there. But there's some people that no matter what, they're just always...
I will say from a clinical perspective, I do find that the injections just make things happen faster.
Yeah.
And I don't ever start there.
Sense, yeah.
I'm not, my whole practice is not injecting. Maybe 30 to 40% of my practice is injections, right? I don't ever start with injections. Like I don't
30 to 40%?
I think 30 to 40%.
Oh, you do a lot of injections these days.
But you get a lot of people who have been
right. You're doing a lot of other stuff, and then you
So I know
pop
I don't
in an
ever
injection before they leave.
I don't ever start with injections. Right. But if they have done all the things and nobody's thought outside of this box, it's not that expensive.
Give it a shot. Yeah.
Yeah. There's very little. There's some
and
risk.
You're fast, so it's
I'm fast.
It's not like a.
And I've been injecting for years.
Yeah.
If it's like, if I'm looking at it and I'm doing the things and everything I'm doing isn't working and I'm scratching my head, I am definitely going to put neural therapy in my to-do list. For sure.
Yeah. I also think about people who, like you said, motility disorders who aren't responding to prokinetics, like any of them.
Yes.
And, I have a lot of endo folks or PCOS folks that just have cysts coming and going and obstructing. And, but the endo especially, I mean, people spend decades with raging endo, never get it diagnosed. And then it's just
all over the place.
And then the surgeons do their best, but they can't get it. I mean, and those abdomens are locked.
Yes.
Locked.
And that's not even talking about the trauma.
Right.
Like the trauma with having that for that many years.
I touch their bellies and it's a lot that comes out with very gentle.
Yeah.
But even, whenever I start abdominal therapy, I always work on the connective tissue first and try to stretch.
Like that's the most superficial layer.
Because it's even skin sometimes because it stretches. And sometimes I can get an ileocecal valve relief with just working on the connective tissue, pulling on it. But those folks, there's no distinguishing. Yeah. Everything's just kind of like
feels
knotted.
like one.
Okay. So Ann Hill, who teaches with me, did cranial sacral. She used to teach cranial sacral.
Yeah.
Like 15 years of it. There's nothing more gentle.
Yeah. I know. I remember her trying to teach me one thing. I was like, I have no idea what you're talking about.
No, it's like
she did some sort of demonstration.
Folks, it's the hypermobile.
I'm sure it works great. She's like, oh, you can't tell. I was like, I have no idea what you're telling me, and I have no idea what.
Someone who's hypermobile, that's so gratifying because their body's just like, oh right, I go over here, back into place, but.
So she then was exposed to neural therapy, similar to how I was. And so she started adding into her patient population. At first they're like...
That's such a great combo.
Well, yeah, but at first they're like, what are you doing? You're my gentle energy person. Now you want to stick me with a needle?
Yeah.
But it's such a great combo. And it just makes treatment go so much faster. Yeah, really. It's such a useful tool to have in our tool belt.
Yeah.
And it's not really that expensive,
Yeah.
So it is one of those things that I am extraordinarily fortunate that I got tumbled into because it is a very useful thing to pull on.
Totally.
Great.
Questions?
I was curious about the ileocecal valve. and motility disorders. I'm always curious about that.
Yeah, and I'm not going to say that. I'm definitely not saying that gastroparesis will go away with neural therapy.
But maybe if you get it regularly, it could help.
I have certain patients who have been surgically altered, and they're just in chronic pain, chronic ulcerative colitis, chronic cancer, stoma, stuff like that. They're in chronic pain, and injecting them, I can reset their nervous
pain
system.
relief.
I would imagine like bowel resections are a no-brainer.
Always. Yeah. Okay. I mean, that stoma scar is going to be it's a big scar. You know what I mean?
Yeah.
Like you have to inject it quite a bit.
And you need it to heal.
And I will also say that a lot of people, that stoma scar is where they end up getting caught. Like if they reattach, that's where they'll have a lot of chronic pain.
So for, again, my patient population here, for folks that are getting laparoscopy with excision from endo, where in their healing, because I have them as soon as they're cleared by their gynecologist to come in and do Maya with me to start breaking things up. And I'll use like castor oil and whatnot in there. When would you start injecting them?
No sooner than 6 weeks.
Yeah, great.
So I want to do that quick.
Yep.
I will say, and that's the scar. I'm talking specifically about the scar. Yep. I do have neural therapists who I trained with in Germany who are like the day of.
Yeah.
Okay, but I don't do that. I don't do that.
But yeah.
And that type of patient, like an endo patient who's got a bunch, I personally would be focusing on their ganglion. So ganglions are nerve bundles, right? So when I'm doing the superficial, I'm heading those superficial nerves, but I'm not in the city.
Yeah.
A ganglion is the city.
Yeah.
Right. And so I would like a pelvic ganglion is very indicated, or depending on where their endo was their endo attached to their rectum?
Yeah.
Maybe we need.
So hard.
How are you going to get to that?
I do a sweet caudal.
Oh.
And that's the info.
As my 9-year-old niece would say.
I think it's called the inferior hypogastric nerve is where I think that's where I'm going.
Just what I was about to say.
But it's a really interesting, like me and Ann do it differently. I go between the coccyx and the sacrum.
Okay.
I'll go in there.
Okay.
And that is very, like people with rectal spasms and tenesmus.
Yeah.
That is a
massive. You can get to that area.
Spasms.
Esophageal spasms, I'll do the GERD protocol.
Got it.
If I can find a localized point, like around where they have pain, I'll try that.
Yeah.
So there's a nerve that pops out between the sternum and the xiphoid. Yeah. There's a little nerve that comes out there that goes to the esophagus. I'll try to inject that guy.
Yeah, those are hard.
Yeah.
I recently had them and I had no idea.
And then I'll also look at my acupuncture, like what's acupuncture, because I'll inject those points.
Right, totally. Okay, my last question is chronic constipation.
Okay. I mean, we all know that chronic constipation is a bitch.
Yep.
Am I going to say that I have cured chronic constipation? No, I'm not. I'll sometimes try some of the Chinese medicine points.
Yeah.
Like, not stomach 36, but stomach 37, I think is better for constipation. So I'll try Procaine there, but that one is, I have better luck with GERD.
Yeah.
I have better luck with chronic GERD.
Constipation is so hard. But
so chronic diarrhea
but maybe
is not as hard.
Adhesions
or endo.
Yeah.
Or food allergies.
Or that's the thing with chronic constipation or diets.
Right. Yeah. Could be many different causes.
Yeah. Do you want to do a little thing on IVs?
Oh, I definitely really, really do. Okay. So a different way of going.
It sounds dangerous to do that.
It's really, I mean,
for the layperson.
Yeah.
As a layperson.
I will use Procaine IVs when
how much Procaine?
Okay, great question. So
100%. I'm just kidding.
Yeah, I mean, the formula that I use is I use 100 cc's of sodium chloride. I'll use probably 10 to 15 cc's of bicarb, and then I'm going to dilute this to a 1% Procaine. Okay. I'll use probably 8 to 10 cc's of 1% Procaine.
Does it burn?
No, because the bicarb buffers it and it's in a sodium chloride bag. Huh. So the reason why, and I will also say, we interviewed somebody on the podcast exclusively on Procaine IVs, and people use different formulations. This is the formulation that I was taught out of my teacher in Germany. The reason why we do that is because the bicarb and the Procaine form this substance called proclusters, which seems to have a little bit of a stronger effect on resetting the nerves.
I don't like the word cluster in IV.
I hear you. There's no clusters in there. I don't know why he calls them that, but they also sell
that one.
In Germany, you can buy like an IV bottle of the proclusters.
Yeah.
So I think it's just a mixture. It's like a complex. It's like
microscopic, tiny.
I mean, they're not. There's nothing crunchy in there. I'm not putting anything crunchy in your veins. That would be bad. Okay, so when do I use the pro clusters? When it's everywhere. When it's
Just reset everything.
Everywhere. Yes, I had a patient who hadn't slept more than 40 minutes in years. And she has this patient is very interesting because so the first time I did a Procaine IV on her, I reset her whole nervous system. She got real quiet on the table. And I have him hooked up to a pulse ox. Yeah. I'm in there with him, like nobody's unattended. You know what I mean? She had not slept in forever. We did an IV. She fell asleep on the table. She walked out and she was actually smiling.
Oh, wow.
She hadn't smiled. She went through an entire series of what's the TNF, like for depression, the
magnetic, TMS or something like that.
Something like that.
I can't remember.
She did. I mean,
that's probably not the right name. I can't remember.
This woman has done everything.
Yeah.
After the IV, I was able to bring her back into her nervous system. She slept.
Okay.
Then the next time she came in, I was like, okay, let's go again.
Her transmagnetic something?
TMS.
Okay,
it is. Okay, go. Sorry.
The next time her brain overrode it. Right. And so I was like there was a thing where I a little bit. And so actually we ended up redoing it like a year or two later. And she kind of had forgotten about it.
Yeah.
She forgot how it felt. Same effect as the first time. Your brain can override it.
And then she could sleep.
Her nervous system is so amped.
Yeah.
I will use it with people who are just so amped.
Yeah.
The other people I use it with is chronic mast cell people.
Yeah, totally.
Like chronic, because the histamine is amping them so
Very
much.
amped, yeah. Yeah.
That's the other place I'll use it.
Yeah, that makes perfect sense.
It's one of my favorite. It's very simple to do. I don't need a hood to do it. It's only, 3 substances, which is what we're allowed to do together. And then, it just is really, Procaine is such an incredible tool to reset the nervous system.
Yeah.
I am so lucky I have it in my tool belt. Yeah. I mean, that's honestly how I feel.
So are we. I don't know how many different areas you've injected on me over the years.
That's right.
I remember, so the first time I was in the clinic, I am not someone who does IVs. I do not do those kinds of injections. And I think you or Megan were showing me how to do a Myers cocktail. And I was like, what if you mess up and drop the wrong thing? And Megan was like, well, I look at the bottles. I was like, I know, but still. So I'm going to leave it to you guys.
It is.
Pros.
Yeah, leave it to the pros.
Yeah, I mean,
I'll stay on my computer.
I will say that I'm not as much of a cowboy as I think I was when I was first learning neurotherapy, but I just have done so much of it at this point.
Yeah.
And, so there are, in the literature, there are documentations that people can form anaphylaxis to Procaine. I've never seen it. We are fully stocked. If anything happens, we have epinephrine, we have an AED, Benadryl, blah, blah, blah. When you're dealing with Procaine, if you have a bad reaction and you hook the patient up to oxygen, it will take 7 minutes to get the Procaine out of the system instead of 20, right? 2 liters flow of oxygen for 7 minutes gets all the Procaine out of their system.
Yeah,
so
great.
that's very, very, in my time injecting, and I started training in 2015, I have needed to use oxygen twice. Once it was clearly a vasovagal reaction.
Yeah.
It was back when I was a little bit more of a cowboy and I was doing a celiac ganglion. And back in the day, I was using a 4.5-inch needle coming in from the back. I
think I remember
it was crazy. I don't do those anymore.
Yeah.
And now I don't need to because I have a better way to do a celiac with much smaller needles, using gravity. But I was cowboying it, and I had injected her celiac ganglion like 100 times before and after. But that time she had a reaction and she got pale and dizzy. I need to lay down. And so what I did exactly what I was trained to do. I ran out, grabbed my oxygen tank, ran it back in, hooked up to oxygen, put her legs up. She was obviously having a vasovagal, but I was still scared.
Right.
And she was like, I've never seen Dr. Gurevich run that fast in my whole life. But that is the one time I needed oxygen.
Yeah.
The other time that I had to hook somebody up to oxygen, I was doing a pelvic and she was a very thin woman. And I ended up what I usually do when I inject is I inject and then I put acupuncture needles in them. They're sitting for 20 minutes. By the time they leave the office, the Procaine's gone.
That's great. That's so cool.
Right. Yeah. It's a great combination. I did not do that with her. She didn't want to do the injection, didn't want to do the injection. Yeah. At the end, she wanted to do the injection. And so I did the pelvic, but she was really little. And so I was too close to her femoral nerve.
Huh.
And then she got off the table right away.
Oh.
and she tripped because I numbed out her leg.
Oh.
And then she was on the floor and yelling.
Yeah.
And then I came back, grabbed her on oxygen. By the 7 minutes later, she was walking fully.
Yeah.
But those were the 2 times I've needed oxygen in the
And
thousands.
you didn't really need oxygen.
I didn't need oxygen for either
it's
one.
Better
but
to just
don't inject if you don't have oxygen and AED.
And know how to use it.
Of course.
Yeah. I mean, just don't do any injections if you're not set up for emergency medicine.
Or if you're a very nervous person.
Yeah. Yeah, it's interesting because I've trained a lot with a lot of medical doctors, and it's very interesting to be like, I'm training neurotherapy with these interventional cardiologists.
Oh, really?
Like they're going in there, going through the nerves, you know what I mean? And they're freaked out about doing a pelvic.
Interesting.
I was like, it's a very interesting.
Yeah. On your thing.
Yeah.
That's true.
It's an interesting conundrum.
Totally.
How was that?
It was great.
Yeah.
It was so awesome. Yeah,
okay.
Yeah.
All right.
Thanks,
guys. See you
Bye.
next time.
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the turd nerd word.